I came from Canada, brought up in BC, and then worked in Quebec, and then I did a fellowship in London. And I tell you, I was just as appalled as you can get, because I was used to Canadian medicine, and when I saw what they did in the NHS, I mean, this was just, you know, I mean, I just couldn't believe it.
And it really depends on, but I would argue it really depends
Yeah.
on when you were looking at it, at what period of time, because they have gone through troughs. And the same
1980
thing,
to 90.
yeah, well, exactly. I wouldn't have wanted to be there either, and it really wasn't. And in fact, I mean, one of the things that's sort of stunning about, it's sometimes misattributed to NICE, but one of the things that's interesting in contrast to the U.S. discussions about economic evaluation of healthcare technology is that NICE has in some ways been cost increasing, because it turns out they've looked at so many of these technologies that the NHS was not purchasing.
Yeah.
And they've said, oh wow, what do you know? They're expensive, but they're cost effective, and they have, you know, approved the vast majority of these very expensive cancer drugs and things. And so you've had a fairly, in the time that we've been studying London, for example, we've seen, when we first started looking at this, with data from exactly that period, rates of amenable mortality, right, so premature mortality due to you know, causes for which there actually are treatments, were higher in London than they were in New York, which was stunning, and it was, I think, mostly driven by really lousy access to cancer drugs. So, because tons of cancers are included in that definition. It's now dropped like a stone, because they've started spending money on this.
Yeah, for things that actually work.
Yeah, yeah.
But I mean, I think that's a completely different question though, like how much is a country willing to spend, regardless, and those are specific cases. But to the broader point, especially with the BRIC countries, there's a limited amount of money that these countries can spend on healthcare, because even though it's a priority, there's obviously other priorities, and there's
Sure.
the point that's the whole point. They're BRIC, they're not the wealthiest countries, so there's going to be a cap at some point.
No, I
as to
think
what-
your
let me
second
just
point is,
finish my thought for a second. So I think that's true, that yeah, countries should spend more money, but particularly in the case of BRIC countries, they just may not be able to, and that's the whole inherent problem of these countries that are not as wealthy as other countries. So in those cases, then the question is, do you want to split the pie really thinly over a huge amount of people? But that doesn't really make that much of a difference, because, and that's the other point, they have a lot of people. So you would need a lot of money in order to really make a difference for a lot of people and reach this notion of universal care. Or do you go in this sort of incremental way where you do meaningful changes but for much smaller segments of the population? And I think that's a real huge problem, particularly in those cases where there is a finite amount of money in not very wealthy countries.
So I think you're right. The issue in India is that the 350 million who are covered by ISBY are in absolute poverty.
Okay.
These are
That's the standard for
the standard is, these are people that are less than $1 a day.
Sure.
right,
You know,
right.
so they're in absolute poverty.
Mhm.
And so, you know, you're talking about a population that even the small amount you're giving them now is more than what they had before. Now, you're right though, because if you spread, you know, if you have $1 billion
Right.
and you have 1 billion people, okay, and you give everybody $1, okay, you're preventing some of those poor people from getting $2.
Yeah.
So for every $1 you're spending on somebody who doesn't need it, you're taking that $1 away from people who need it. So you might be able to give those 350 million $3 if you didn't give anything to the other
Right.
600.
Yeah, so I was just processing all this already, and so this might sound like a little stupid question, but when I came to US for the first time, one impressive thing I saw was SSN, which is like a unique identity for every person, and all the records, like financial, in fact health related, is stored in that kind of system. And I was reading about Taiwan and the smart card thing that you mentioned, which has all the details and health related information. But India doesn't have that kind of thing, and they're trying to build some kind of thing for all the people across the country. And in terms of equity, so there are people who are not poor, but they belong to reservation castes in India. So we have like a reservation, very messed up system. So they're like really rich people, but they don't have, because they're from a reserved caste, they are given
They're
priorities,
classified.
classified, given priorities, given benefits, given subsidies. So those subsidies which actually do not belong to them, they're just going to them because they're from a reserved caste, and the really poor people are not able to get those kind of benefits and subsidies, which can really improve their healthcare status and everything.
What is a reserved caste?
Yeah, so this caste.
No,
The
what is
lower
a
caste.
reserved caste?
Like Brahmin or the
No. They are like they're called scheduled caste, scheduled tribes. They're basically the backward classes of the society. They're not religion based, but they're caste based. And like recently only there was one of the castes in country who wanted to be called themselves as backward class so that they can get the benefits from the government in terms of employment and benefits and everything. So my question is, do you think that developing a very unique identity system or a system like SSN per person really helps to bring in that equitable distribution in healthcare? Or are there countries like, but I don't know about China, Mexico or Spain or Brazil, if they have like a unique identity system which is helping their healthcare system to provide equitable and subsidized care to the people who really need it?
Well,
Can I mean, just to clarify, like our social security numbers are not attached to healthcare. Like that's only financial in this country. I can't go to a different health system and have them pull up any record that have ever been before. The only thing that works for is to get tax information related to how much you paid to health insurance,
Okay.
but not like for instance NHS, like everyone gets their insurance number in the UK, and then like that is what lets me go to a doctor. Like we don't have anything like that here.
Okay, so you
When
must
you
be
say we,
talking
you
about
mean
Canada,
US
right?
or
Sorry, in
Canada?
the US we
US,
don't have
yes.
anything here.
Except for the Medicare, it's actually you use your social security number.
Right,
And you put an Emma at the end of it.
right, but that's only Medicare.
Okay.
yeah, in Brazil
And
you
that's
have
not
the,
even in Canada and UK, like
The UK does it, everyone has an
The National
insurance
Health System,
number.
they do
I
it.
don't actually know how it works in Canada.
No, Canada doesn't use the SIN for healthcare, it's a separate number for healthcare. And it's, by the way, Canadians, another myth about Canadians is people call it a single payer. It's actually not a single payer. It's actually 10.
so
Plus
they
one.
the Canadians they also sorry, the Canadians also they do have a card system which they can just go to a provider and they can,
Yeah,
they don't have to
it's like a
the
credit
entire
card.
information is there on that card, right?
No, only
No.
just a number.
No medical information, just
No, just a number.
eligibility information.
Just a
Reimbursement.
The spread of electronic health records around the world is not nearly as great as the hype would suggest.
exactly.
Taiwan is a leader there.
Yeah, absolutely.
we have that.
in Brazil you have the
But
CPF,
let's get back, all right.
which is the social security number,
Let's get back
and then you
to
have a number
Alex's,
for the universal health coverage.
But then it relates to the
To Alex's
specific
point,
person in the
let-
country, right? Nobody can create a fraud on that number.
No, so you have everybody that is born when you get registered, you have a CPF, a social security number, it's like we call CPF.
Yeah.
And then when you want to register, everybody's entitled to everything on the universal health care. But you have to have a card with your number. You can go to any healthcare provider and you get that card, and that card is your insurance card for the universal health care. But that card does not store any information of your treatments. It's just a card that you can have to show when you, and if you don't have it when you get run by a car, nobody cares. They just make you another one. It's just a number.
it's for eligibility.
It's for eligibility, but everybody's eligible, so if you don't have one of those and you get run by a car, they just make one for you right there.
But that card is specifically like associated with one person in the entire country, right?
Yes.
Nobody else can take
But-
advantage of like
No.
person who.
No,
Yeah.
it's attached to your
That's what my point is. Like I mean, like
Is that
maybe
not
that kind of system.
No, you
can-
cannot use, like, he cannot get my card and use it, but he doesn't have to because
He has his own card.
he has his own card. Why would he use mine?
Mhm.
I mean, the card thing is kind of interesting, and it helps, and all countries are trying to sort out their identity, that kind of thing. But when you're in Africa or India, the card doesn't really have an address, and its post box is, 3 trees down from the second road off the village. And so to actually attach that to individuals is
Exactly,
problematic.
yeah.
And then the second part is, villagers tend to not bring cards and stuff like that. So it's a good thing, but it's very hard to put in place. When we did the insurance system, or helped Ghana put in place their insurance system, they were issued cards. And it didn't actually, it helped a lot, but it didn't solve the problem that people forget it, the cards get damaged. The cards are traded, so people will give you a card to somebody else and
Or
then they'll go
maybe
and
it can
use
be
it.
mandated. Like,
Sorry?
or maybe it can be mandated, some kind of rule which mandates this kind of thing, like if you don't have the card, you cannot get this.
Yeah, but then the woman we had that, and then the woman shows up with her baby, and then, it's in the press that, she showed up with the baby and she was refused because she didn't have a card. So, for each example, there's, it's a move in the right direction, but, there's no silver bullets here. So,
Well, Michael, do you have any reactions you want to put on the table before the class is over, or?
Well, I just wanted to mention two things. First, to go back to what you were saying before, I think you're right in terms of the BRICS having enormous problems that, OECD countries don't have, and it would certainly be unfair to think about their spending in sort of those standards. But when I was talking about low spending, I was talking about it as a percentage of GDP. So I was talking about it accounting for the size of their economy, and it's still quite low relative to the size of the economies. Now, having said that, I do think that there should be an active debate about when you have the kind of extreme poverty that Alex was describing, whether or not spending additional percentages of the GDP on health care is the sensible strategy. You could make an argument that spending money on basic public health infrastructure might be the smarter way to spend the next several $billions as opposed to expanding healthcare, that making sure that people have decent water, unlike the United States, or sewage treatment and all the rest would be a fine way to do that. So I do think that's an important kind of thing to keep in mind when you're thinking about sort of broad national priorities in terms of what can be done to invest in health. My main reaction to what Alex was saying that I think is important for your subsequent discussions is that he kept pushing you, whether it was the definition of BRICS, the definition of universal healthcare, the definition of reform, to sort of get past the labels and the rhetoric and the jargon to sort of disentangle this and think about sort of real implementation. Think about this in concrete terms of what this actually means, so that you don't end up talking past each other because you have very, very different contexts, different sorts of problems. And I think that's a really powerful and important lesson, because there are extraordinarily different starting places, and you're looking around at these different countries. And in China, for example, you were giving the example of the clinic in India, and as you were talking and describing this sort of remarkable technology in this place that you visited, I kept thinking of Beijing Children's Hospital. In a Beijing Children's Hospital, which is one of the largest hospitals I've ever walked through in my entire life, I didn't think I was going to get out the other side of it, you had two things going on simultaneously which were pretty stunning. On the one hand, you had surgical theaters that were absolutely stunning. And I spoke to a bunch of the Columbia surgeons who were working and doing surgery actually with the Chinese surgeons. And they said, technically some of the finest surgeons in the world, wonderful theater, just like doing work at home.
yeah.
But within the same hospital, unlike the clinic you described, you had queuing that went around this very large block with people showing up from the regions and coming in.
Right.
And I said, I'm a little confused. I said, basically they had no triage system at all. You just showed up, and I said, well, is there a way for people at the back of the line who have more urgent problems to get to the front of the line? And they just looked at me like I was crazy. It took them one at a time, and that was the system. The emergency department, completely packed emergency department with people waiting there for days. And culturally, a lot of people hooked up to IVs for no good reason, because the view of good care, it's a bit like dealing with the French, who always want you to write a prescription, is the Chinese wanted you to, stick something in my arm, and so they were providing people with saline, because that seemed like the most reasonably safe thing to do, even though they were still worried about infection. So I guess the point I wanted to raise is that within Beijing, for example, it's not just that you have some places doing sort of remarkably high-tech, advanced care at the same time you have first-level hospitals that are really pretty dangerous places to go, where you wouldn't want to walk in. You actually have those sorts of contrasts in terms of good management and high-quality care, sometimes within the same institution. So it's really quite a fascinating delivery system. And so you've got a bunch of the reforms in China have mostly been at the financial on the financial side of trying to sort of do this, but they're trying to actually push on the delivery side as well, because one of the things that happened kind of post Deng Xiaoping, or as part of Deng Xiaoping's economic reforms, is a bit like the Russians who decided that they wanted privatization, just privatize everything. You know, in 1978, they decided that market competition was good for everything in China, and so they dramatically reduced the subsidies to a lot of the public sector institutions, and it turns out that basic public health, vaccinations and things, don't really make a lot of money. So what do? They turned to the pharmaceutical industry, and they ended up making a lot of their money by pushing drugs that people didn't need, and they're now trying to unravel the legacy of that problem in China. So
really misunderstanding of public, of public goods and,
completely, just misapplication that recognizing that market competition can be good for some parts of the healthcare system and don't make sense for others.
yeah.
It was just sort of a blanket application. And that's a very different kind of problem than the one we're talking about in India. It's certainly a different one than the one we're talking about in Brazil. And so getting past the labels and getting to the details of what the problem are.
Well, I think there, it's very,
It's a governance
And
issue,
then-
right?
what?
Like healthcare reform can't fix that discrepancy. It's a governance issue where some people are just getting preferential treatment.
That is,
Well-
I think we're talking about something a little bit different in the sense that, yeah, that's one kind of problem that's probably common in both of those countries. But this was more the failure to recognize that certain health services are not going to work unless there is some kind of, some level of public subsidy, because you're looking at a public good as opposed to something that can, in theory, work like a market good. I mean, you know, so if you take kind of Kenneth Arrow's critique of markets in healthcare, it turns out that you really need to unpack that by type of service, because the problems he was pointing to make sense for some healthcare services and not so much for others. You probably can use market competition for something.
Related to that, and something we've talked about here before, I think it has to also to do into what you were saying before, people's perception of whether health and having access to health is a right, and whether that's sort of like in places where it is part of the Constitution. We were, when, I forget his name, the guy who came to talk to us about Mexico, I'm sorry, I blanked out, yeah. So one of the things he mentioned is that, talking about Spain, people demand access to public health because it's a right, it's okay, you know, that's what they think they should get. But in Mexico, that's not the case at all. It's sort of a privilege. If you do it, it's like, oh, thank God I got it. It's not really something that's considered a right. And as long as that's the case, then there's little pressure on governments to do that. People tend to think of health as a market good instead of something that deserves subsidies, because that's the way it's treated. So I think that's sort of a deeper question that goes both to the culture sort of around public health and how people perceive it, and whether it's part of the government sort of, it's in a constitution in a way that, like in Brazil, makes it clear that it's a
But it becomes a social
right.
thing, so it's like,
Yeah.
you know, it's like Canada and Britain. I mean, people would,
die if you took it away, yeah.
well, you would have a revolution.
Yeah,
People
absolutely.
would, you know,
But
really, the
that's
government would
crucial.
really lose if
But
they
it
took
does
away
create,
healthcare.
yeah, it does create that
So-
pressure on the government to at least, you know, try to do something about it, whereas in other places, but particularly some of the BRIC countries, I don't think that's the case.
But you see, here's the example. So the Canadian healthcare system was really designed by a person called Emmett Hall, who was the person who was the commissioner for two of the large commissions. And then they had a review in, I think it was 1987 or 90, where they then did another review saying, well, is the Canadian health system working or broken? And the commission came out, so it was like 30 years after the original commission. And basically, the commission came out and whitewashed the system, saying, we have the most wonderful system in the world. I mean, there's nowhere else in the world that you have access to healthcare like we do. And therefore, you really shouldn't touch the Canadian healthcare system. You know, after millions of dollars were spent on this commission, they came out with that conclusion. You know, and there were major problems in the Canadian healthcare system, not because you didn't have access because you had the insurance, because that was working. There were many other problems that weren't working. And so I think this is where one has to be really careful with
Of course,
reform.
after that report, I think the overall budget was cut.
Yeah, and the budget was cut, because people said it's working well, so we'll cut the budget. So it's a good example of really be careful with the word reform, and really, I like your way of describing that. You really want to unpack this thing and understand when people talk about these kind of things, what is it actually you're talking about? What is BRIC? What is universal healthcare? What is the thing what is it you wanna fix? Let me understand what you wanna fix, and how do you think it could be better? And how does that affect a whole bunch of other stuff? Because you might fix this, and that has a terrible effect on that. So you wanna look at the connectivity in a complex system, that you don't go and fix one thing and then make something else much worse. And that's really what happened in Russia and in all of Eastern Europe, is there were things that were unresponsive. There were huge problems in the Shemenko healthcare system. I mean, I'm not saying there was any problem, but they came in with a reform that broke everything else that was working. So people ended up not having access to care, and huge whatever. And there were big problems, but they fixed the wrong thing.
Well, we started out the class by making a list of all the different things that are covered under this vague term reform,
Yeah.
from electronic medical records
Right.
to integrated records,
Sure.
to cost
That's great.
containment,
Yeah.
to promoting equity, to whether healthcare is a right for all, to the public-private mix, to
Absolutely.
the theory of managed competition, and went on to say that when you unpack all of that, health reform seems to be nothing more than health policy. When I interpret what you said I would ask you whether I'd ask the whole class, in fact, in our next sessions, whether we can't think of health reform in a way that Michael's written about it with Larry Brown and others, as different ways that different health systems ration healthcare. Because whatever reform you have and whatever system you have, the way it works is actually to take that amount of money that you talked about and figure out how it should be spent across populations and across services. And the decisions made in England put a much higher value on access to primary care than in the United States. And the decisions we made were to invest in massive technology, state-of-the-art hospitals and technology, with much less emphasis on access to primary care. And we could go on and on. Strong rationing in Britain on the hospital side, on dialysis, far less rationing on treating patients with chronic diseases, primary care, even certain sides of long-term care. The article we read with Larry Brown and his colleague from London School of Economics. Can't remember his name. A little tough article, but one of Adam Oliver's, Gwen Bennett and Larry Brown,
Oh, right.
on the rationing of care in Britain. In any case, I ask you to think of the next 4 weeks, how have Brazil, China, Russian Federation, and India made these choices of allocating very limited resources across primary care, hospital care, public sector, private sector? Because they've all made rather different decisions. And it plays out in who gets what, in ways that you've illustrated. Now, Bangalore, the other thing is, what can one infer from examples? Bangalore is the richest state in India. It's an extraordinary story you're told. I didn't know that one. It's an extraordinary story. But you have examples of a private hospital in Delhi where they only take people who can pay, and nobody's waiting to get in.
Sure.
In fact, there are empty beds and empty wards with new hospital buildings, a little bit like Kenyatta.
Sure.
Right? So you have that example, while people go to the public sector and get badly treated, or they go to the private sector where they pay far more, but it's not worth going to, and it's not regular. And that's in the same country, but that's in Delhi. That's a whole other story. We'll deal with Delhi, well, parts of Delhi. I'll take a little bit of it next week to deal with one thing I've been working on with Michael. Now you see who he is. And you'll see him again on the China side when we talk to these two Chinese colleagues. Any final questions from you? We have about 3 minutes.
I have a question.
Yes.
If you have an opinion on Brazil, and
Alex has got an opinion on
do you
everything.
think they overdid it with the SUS? Because Brazil is in a difficult position right now.
It's a good question.
So you think they would be in a better economic growth position if they hadn't spent so much on SUS?
Ooh, that's a good one.
What
I mean,
is
obviously they have a lot more problems.
what is it
There's a lot of
spend?
problems.
Right now.
What is spending so much? Because they actually spend like 9% of the GDP on health.
Which is relatively a lot. That's what Europe spends.
Close, yes,
Yeah.
yes, yes. And
So
it's
for a
much
country
more
that's
than India.
not anywhere near that level of GDP per capita, like,
I mean,
is that
Well, that's
too
proportionate.
It's
so it doesn't
proportional,
matter.
yeah.
you know,
That's
this,
not, but, so you're foregoing investment into like actual jobs.
No, this creates a lot of jobs.
Yeah, a lot. The health market is huge.
Sue's created a lot of jobs.
Very a lot.
He wouldn't be here now if it weren't for
Yeah.
those jobs.
you know, the one thing you should keep in mind is an example actually from Africa where I was involved in the 2003 Abuja Convention declaration. I don't know, do any of you know the Abuja Declaration in Africa? So it was a bit coming back to the point about, you know, are you spending enough? And you know, at that time, a lot of African countries were spending 2% of GDP on healthcare from the public sector. And it was, you know, based on Jeff Sachs' analysis and others, there was good evidence that you needed to be spending about $35 per capita in order to reach what was called the NGG determinants. So, you know, with a lot of pressure on the World Bank, myself included, and others, you know, the ministers of finance got together and they passed this, you know, resolution, which was amazing, called the Abuja Resolution, which was basically saying that all governments sign on to moving towards spending 15% of government spending on healthcare, government spending, not of GDP, of government spending. And then we came back and did a, you know, so everybody signed on to this. And then we came back about 4 or 5 years afterward, and then we had a look at, you know, where had they gotten to since the Abuja Convention. And the shocking thing was that actually about 50% of the country in the region were actually worse off than they were at the time of the convention. So during that 5-year period following the reform, they had actually gone backwards. So I think, you know, once again, it highlights the fact that, you know, we didn't even get a chance to talk about that. There's reform on paper and there's a reform in action. And, you know, sometimes maybe the reform in action, the actual changes, the implementation is much more important than the symbolic things. And we know that from, you know,
Sure.
every country in Latin America has a constitutional right to health care, you know, but we know that many of the countries don't provide health care. So really, the implementation, the devil is in the detail there.
Thank you very much, Alex.